Good morning to every one of you, just from me as well. First of all, I would like to thank Alexia. Big thank you for having me here, and a big thank you for giving us the chance to have very good discussion yesterday, last night. It's been very interesting so far. It's a perfect location. It really is fun being here, and I'm glad to tell you something about not really scientific purposes, but the clinical experience, some of the clinical experience we had with it. Actually, it's going to be, I think, 7 or 8 cases from the last half year. We used the BioBall system. We do about 100 revisions per year, and actually, while looking through the data, I use for my revision cases in about 20% the BioBall system. This might be a complete revision, this might be just a cup or stem revision. However, in my clinic, mostly only for revision surgery. So that's what I'm going to be telling you about today. Some aspects of revision surgery in the hip, the possible planning, which makes it a bit easier but doesn't give you all the solution, even if you do a very thorough planning, and the possible pitfalls which might lead you in the wrong direction, where you need systems which can assist you in the long run to solve the problems you run into during those operations, and then the implementation in form of some clinical cases which we can discuss. I've got plenty of time to talk this morning, and I don't want to bore you too much, so it would be great that you just ask questions right in between. If you see a slide and you want to talk about the slide, or if I do say something which you might not be really the same position with, just let us talk in the beginning and right during the talk, so that it might be interesting for everyone and that we can have a discussion in the end as well. First of all, since many of you aren't really from Germany, and Alexia already mentioned that I'm from Bremen, just give me, let me have a quick introduction of, I got no idea why this is not running here, doesn't matter, of where I come from. I'm starting out at the University of Hamburg after I did my PhD in Sweden, in Lund, and then I went to the University of Rostock, and from that I'm now in Bremen. Very nice, very old city. Not many people know so much in Germany, in the world, even though we have about 600,000 inhabitants. What we are famous of are the Bremer Stadtmusikanten, a story by the brothers Grimm. Whenever you come to Bremen, you should be touching the donkey down by his foot, and that will give you luck for the rest of your life. So you should come to our city and just see it. Even though the city is rather old and very close to the sea, the hospital I work for and where I run the department of endoprosthetic, foot surgery, pediatric surgery, and general orthopedic surgery is rather modern. We do about 1,000 joint replacements per year, of which I was just saying about 100 are revisions. We do almost 1,000 big foot surgery operations, and some minor things. So it is actually that there is some quite an experience. And what I feel is a nice part about it is it's a specialized hospital. So we have at that hospital only orthopedics. That means we have a second department for spine surgery, and we have a third department for sports orthopedics, and that's it. So patients coming there, they're coming from all over the world because of the hotel-like facilities, and that there are not really sick people around. It's nice working too there. Actually, I wanted to talk about clinics today, and I should start at some point, even though I have plenty of time. And what we have to talk about is the increased requirements we do have due to the increasing numbers of hip revisions. In Germany alone, there are about 28,000 per year. And the cases aren't always very easy. This is a case from Rostock. I mean, there's a bit like both hips are totally worn out, the cups are diminished somewhere, there's a lot of cement somewhere around, and you have to find solution for this. You can't just, people, even if they had this 20 years ago, in general they're not very sick. They want to live, they want to continue with their life, and they want to be quite active still. So they come up and say, well, I can't walk right now, but if you operate me, I at least expect that I can play tennis again. It's not really that much, but it gets close to it. So if you have a case like that, you should really think what to do with it. And the general questions which I think we should ask ourselves as surgeons is, what is our revision concept? Like, what do we want to do? Do we want to do cemented? Do we want uncemented? Do we have big, small cups? Do we use full flaps or something like that? How can we replace the bone defect? What to do with it? And last is, and very important, and that is where the BioBall system at least at the end comes into the consideration, is what's with the soft tissue situation? How can I reconstruct the lever arms of the muscular system in order to work again for my patient? And that is big planning before. You can't just go into that and say, well, it will work out somehow, and if I have some solutions. The question now is how and what to plan. And that was more or less planned as the first part of my talk. And the question which we can consider is, how can we reconstruct the biomechanics? So we first don't only think about the soft tissue issues, but we think about the biomechanical issues. And what is the biomechanical issue in the hip? It's the rotation center. It's the rotation center of the hip, which I have to reconstruct in some way. It has to be at a certain point. I can't just put it anywhere just because I might get an implant stable at that area. And if I have a plan about the biomechanics and decided what kind of implant might be the best for it, I should think, what kind of implant do I need? And is this an individual implant, or do I have to have, or can I use a standard implant? And what do I need in addition to the standard implant? For me, it's actually quite easy. I have the complete BioBall system at the hospital all the time. So even if something goes wrong during the operation, I can just add that to my planning. And that actually is quite a big point. Is there's no, like if you have a big revision, you always should have something on the backhand, and that would, for instance, be the BioBall system. And there's the question is, how quick is such an implant available? Not only the cup or the stem, but do I get this system? And that's, it's my personal recommendation, and I don't get paid for it. You should have a system like that always in your OR. Because then you have always a chance, even in primary surgery, there might be something going wrong. There might be some young operating assistant who just cuts too much bone away. And then he has the problem with the luxating hip during the operation. And he needs some way back out of that. And you can't just remove a stem and put a bigger one in and just prolong the operation for hours. It's an easy thing just to put an adapter on and just try all the different adapters which might work for you, and then say, well, this is a solution, even though something went wrong in the beginning. But what I meant is, if you do an operation, you have to have all those things available, and you have to check when they are available and whether they are available sometimes. And then at the end, it's also the surgical issue. It's like, what approach do I use? How can I diminish the muscular damage during the operation and all that? So these are things which I have to think about just as well. And those points all together, they give me an idea what to operate at what time and how to do best. And in order to do so, there are some classifications. Worldwide, more used is the Pavlovsky classification, which is more or less the same. It's just the different defects of the acetabulum here described. I think this is worldwide the most used classification for it. However, if you look at some of the scientific work, this is a rather like 5 to 6 year old publication where there is a lack of correlation between the preoperative X-rays and the intraoperative status. And like we're talking about 50%. So if you open up, like you did all the planning and you did do your X-rays and you say, well, this is a good solution for my patient. And you open up, you take out the implant which has been there, and then you have a big defect and you just stand there. If you're not prepared, you just stand there. I've just talked to some colleagues from the Endo Klinik, which is actually the biggest endoprothetic hospital in Germany, and they say, which I found amazing, that they have 50 cases per year coming into their hospital where some doctors just stopped operating. They just said, I couldn't do it anymore, I didn't know what to do. And then they just suture it and they send it to the endo clinic. I mean, imagine, like for the patient, this is just, but for you as a doctor, I mean, like I've got a big ego. And then just sending, I just couldn't do that. So coming back to the point, you've got to be prepared. And the reasons, of course, are the complex anatomy of the pelvis, the inter-individual reliability of the situation you find there, and the assessment of the visible defect in the X-ray. So that's why we recommend, from a certain degree of, let's say, defect in the acetabulum, we need a CT scan. So just that you are prepared. That doesn't solve everything for you, but Popovsky, 2 or 3 defects should be having a CT scan before, so you know at least close to what is expecting you. And then even if you have done all this, you still might run into certain pitfalls, which might give you trouble. And one of this is as I mentioned before, the analysis of the bone defect. This is one of my earlier works. There is a small defect here, but thinking and being not too experienced with big implants, well, this might work with a regular, maybe slightly increased implant. So preoperative planning has been done by that time still with this paperwork where you draw on what might fit on there. Then you don't really think about the status after debridement because you just want to go into the case, and also not thinking about maybe some cement or some other implant parts like screws to be there. And that's the point. Yeah, there might be change from one defect size to the other, and then you are in some trouble doing that operation. So that's actually what happened, classified as type 3 defect, and put this mega cup. Actually, this is part of training. I know that worldwide, especially in the Anglo-American societies, these jumbo cups aren't very well recognized. There are some Germans which are not trained so much in the Anglo-American who brought this jumbo cups things into Germany, and I found at some point that they do work very well for me as well. So it is a solution to use such a cup. It's not no necessity, but you will see some of those cups in the cases later on, because I still am using those, and I'm personally getting well along with them. And I find it very interesting that my younger colleagues who just start working at the hospital with me and do revision now, they do get comfortable with the implants as well. So it can't be just such a bad implant. The only thing is, once this been osseointegrated, you can't remove it. There's no chance. If you remove it, then there's a huge defect in the pelvis. I mean, then you just can look for an individual solution, for sure. So what happened? If you look at that, position is quite okay. Implant is in place, but there's a break here of the bone as suspected, and the implant just flaps over and the hip even luxated. So that didn't last for very long, and we had to do some revision again. So keep in mind that there is always a risk of acetabulum fracture in revision surgery, and keep in mind, I'm just like gonna tell you that during the whole talk again and again, you have to be prepared. And you have to have everything in place. And this is not a story I don't have the case here right now, but it's happening last year, the end of last year. There's a patient and had a fracture in proximal femur after having a hip in there. Actually, the hip was broken too. So I decided, well, let's just, I don't know whether I might just even have some of the pictures of the case, but I just decided like what to do now. I just replaced the proximal part of this femur because the company which sold this said, well, there's a chance of just having that, and I ended up with a total femur replacement because he was having a knee anyhow as well, and then the fracture got so low down that I just decided, well, let's do the total femur replacement. I'm not saying that everyone has to have everything for total femur replacement at home, but if you do more than just 20 revisions per year, you should actually think about it. This is what I'm, just a small sample of what you might find during the operation, which you don't see on the x-ray before. It's just all this debridement, and debridement, of course, leads to bone defects here in this case on the femoral side, and you can't really plan that in the beginning because you don't see it on the x-rays. And this is not, it doesn't look much, but in general the whole thing, there was it wasn't just like a peach size of debridement, which was just taken out there, and then how to get this implant stable again is the question. Good, I was already telling you the remaining implant parts, flap screws, cement rests. One of my very, very favorites is cemented screws. This is really fun to remove. Like, it can just take you hours and you just give up at some point anyhow. But you have to be maybe able to tell yourselves at some point, well, I just leave it in. But if I have to leave it in for some reason, then I also have to find a solution for it. Yeah, I'm not taking everything out. It's just like you'll see in a few slides a case where the burr just broke. I mean, I'm not going to take out a burr which is just somewhere in the iliac bone. That would be just giving too much defect. I just left it in there, and patient lives well with it. So at some point you have to say, well, this is maybe until this point and not further. So I don't take everything out, and I might just leave something in there. What I always manage is to take out the screw head, but the rest of the screw is at some point just staying in the pelvis at the revision surgery. So here, a case, what to do with that? If you do the revision, you leave it in, you take it out. Any opinion? Anybody who just thought about that before? What do you do? Yeah, I do too. Just forget about it. However, that was like one of my fellows had this year actually had a press fit implant, and he just put it all the way through into the small pelvis. And I was standing there like, what to do now? I mean, you have to take that out. So that are big operations with big defects as well. So again, you have to be prepared for anything. Another pitfall. We always talk about stability of our implants. And actually with those kind of implants, especially with the cementless implants, you have to talk about primary and secondary stability. The primary stability is the implant just locking somehow into the bone. For instance, if you have the femur, which is round, and you have the implant, which is angled, then there are 4 points where the implant gets stuck. And that's the primary stability. And the secondary stability is the osseointegration of the implant. That's why the surfaces of the implants are treated in some way. Plasma sprayed or titanium sprayed, many ways of treating those. This is in order to increase the osseointegration, the growing of the bone on the implant. And between that time, the primary stability and the secondary stability, the osseointegration of the implant, there is some time and the patient still wants to walk during that time. So the primary stability has to be good enough for carrying the patient. I don't know how that is in your country, but we do have patients who do weigh about 200 kilograms and more. And you can't tell them like for 3 months not to weight bear at all. So primary stability is a big thing. I talked about that before, but the second stability is how quick and what can I do for a reliable bone bearing? And how long is this regeneration time for the bone to heal? And what is the reliable parameter for bone quality? Actually, we did a study during my time in Rostock, which was quite fun. I don't know whether you have a discussion at your countries too. I mean, the Swedish don't, because with the Swedish it's like all cemented. But in general, most countries go parts uncemented and parts cemented. And then there's discussion about what time to use a cemented implant and whether you use an uncemented implant. And it's always like, well, we have an age about 75, and then we do cement. But why? Actually, if you look at the registers, there's no data which support that cemented or uncemented one way or the other is better or worse. The Norwegian register says that if you have patients younger than 55 years of age, you should go uncemented. But that's the only register, to my knowledge, which just gives a clear direction to uncemented and cemented. And I don't know why I started out with this. Yes, I was going to go with the study which we did in Rostock. So you leave the surgeon with the possibility to say, well, you decide whether, according to the bone quality, whether you want to go cemented or uncemented. And so what we did a density measurement, bone density, dual x-rays, before the surgery. And we didn't tell the surgeon. And then we asked the surgeon, how would you describe the bone quality and how good was that in your opinion? Actually, there was no matching at all. So either you say, well, the bone density measurements don't make any sense, or you say, well, the surgeon doesn't make any sense. But there is no really reliable parameter for bone quality. That means, to me, I have to wait for the X-ray to show that the implant is in secondary stability before I really start weight-bearing the patient. And that's a long time. Until the X-ray gives me that information. So, to my opinion, there's actually no ideal concept for this secondary stabilities. This is, just like always, collect your own experience and develop your own concept. Is our concept, my concept, after cementless revision, 6 weeks, partly weight bearing with maximum of 20 kilogram, no flexion over 60 degrees, no rotation, no abduction, no adduction, and only after the 6 weeks, take an X-ray. When you see that there is already some integration of the implant to the bone, start with the rehabilitation, but not before. That's my way of doing it. it's the way which has been mostly used in Germany as well. I know that there are other ways of dealing with it too. For instance, the Swiss, they're always a bit slower. I don't know whether you heard that, but the Swiss people are a bit slower than the rest of the world. So it takes them 3 months before they start weight bearing. It's just, I don't know. Just the way it is there. And then we come back to the cases where we really do need the adaptive system with the soft tissue. We have to reconstruct the lever arm, the muscle function. And for that, not only the rotation center is important, but the distance of the femur to the pelvis has to be reconstructed. The length of the leg has to be reconstructed. And still, you shouldn't touch any nerves if you are in that. So, because the worst thing which might happen to you is that you have a good X-ray and the patient can't walk anymore. And the insufficiency of the gluteal muscle is not only going along with a big risk of dislocation, but also with a big loss of quality of life for your patient. And that's something which you really don't want. This is one thing to have a good X-ray and come out of the OR and say, well, this looks very good. But actually the most important thing is to talk to the patient after 6 weeks and say, well, how are you getting along? What's your pain? And how good are you walking again? And so for that, you might need this possible, whether this is now really the best solution might be discussion, especially since it has been luxated, which is partly due to the very small femoral head. However, something you should keep in mind is not only the bone quality or the orientation of where to do the implant and the implant design. This is a study from 2009. It's only 23 patients which been treated with a trabecular metal shell, but with rather large defects. And the interesting thing is that the rotation center has been verticalized for in a medium of 26 millimeters, 2.6 centimeters. Shorten the leg, getting away the muscle function and having all those problems. That's a big distance. And if you, for some reason, don't get the implant in any other place situated than up here, then you have to use those adapters. I'm not saying like you should do 47 millimeters or something like that, but even with the smaller distance, like I must admit at some points I'll just go for, even in my planning, I go for a centimeter or a centimeter and a half, knowing that I have the better bone stock there. However, if you are above the foramen ischiadicum, here the pelvis gets very thin and you don't get anything stable there anymore either. So it doesn't make sense to increase it as much as possible just to get the cup situated in the bone and stable, because up here it won't get stable anymore. Makes it even much more difficult. So if you do that, if you do those reconstructions and there is an increase of the rotation center, then you do have a high risk of not only impingement but muscle insufficiency with the result of luxation of the hip. So that's the solution we came up with. Also still using a Barrette adapter, but having this big mega cup where the rotation center is decreased by about a centimeter or half, 1.5 centimeters, in order to have a good functional system back in line. And there's a patient. Talk about the patient too. They get older, as I mentioned before, and the patient also is not, well, they have high expectancies according to the outcome, and they don't see the point in, like, we're doing our best, it's very difficult, it's been a very difficult operation, you had a very bad situation, this is the 7th revision which we've been doing now to you, 5 others have been done before somewhere else, so it can't be very good. Well, they don't see that. Especially when they are older, when they have dementia or other secondary diseases, which might increase the risk of infection as well. And then you have to do another revision. So this is something which you should keep in mind as well, that you have to do some dislocation prophylaxis. And that's the reason I'll show you some pictures as well, why I use the dual mobility in older patients if I have a femur fracture. It's like, I'm not a trauma surgeon, but at some points there are also trauma patients coming into my hospital, and we do of course treat them as well. And if they have a proximal femur fracture, I'll show you one of those cases in a while. I just prophylaxis. As a prophylaxis, I do a dual mobility solution. And actually, I didn't have so far a redislocation of the hip. So they are really working very well. We don't have the 20-year experience we might need in order to say, well, this is going to be the best solution ever, and we use it in all patients all the time, which is always also a price question as well, of course. Here we start with the first case. It's a 54-year-old male, so rather young patient who just came with a peripheral replacement both sides. I think the right side was 10 years after implantation, the left side even 12 years of replacement, and patient suffered from diabetes and alcohol abuse with the expectancy of some delirium after the operation. So let's plan this and think about what to do. As I said, with the foramen ischiadicum up here, from here on we have not enough bone stock, but there is still some bone stock there. So that might work with a regular cup quite well. Do some more planning and thinking, why did the joint get loose? So the question is, how many of you would do a probe before the operation when there's some kind of infection? None. Well, me, I didn't do either. We have a rule where we say if the implant is in place for less than 5 years, but this is just my rule, this is my hospital rule, this is nothing which you can just read somewhere else. But if you have a replacement which is older than 5 years, then the chances of having a septic loosening is rather small. So do I really have to put my patient in the position, pain, infection risk, something, to take a probe from the implant? I don't think so. Why don't I think so? Because there are a lot of data which support one-stage revision, even in infected joints. Like the before mentioned endoclinic, they do use quite often the one-stage revision. We, in normal cases, in infected cases where we know the infection, do that sometimes too, but mostly we do secondary or two-stage revisions. However, since this has been in over 10 years, the chances are very small. So I did take probes during the revision surgery, but I don't feel the necessity to take them before. So what else do I have to do, or what do I plan? I told you I love those jumbo cups. This time I used it with a flap. That was the burr I talked about when I was burring for this screw. There's some bone put behind here. I use actually 3 screws. You can see them here, 1, 2, 3, and then the flap also additional. I think that's a rather sophisticated solution for for the cup to get that stable. And then this is a bit stupidly X-rayed. However, we were managed to reconstruction the lengths by using just a normal BioBall adapter with the length of M. So why did I use it then? I could just put a head on it. Well, you can't. You have, if you want to leave the stem in place, you can't use the same conus anymore. So what do I do about the conus? I have to do some revision. And since this is something, I need modularity. I need that with my knee joints. I have the same knee for the medial replacement as I have for the surface replacement. I even have the same knee with the same cuts for the stabilized knee systems. And I need the same thing here. And since I have the Moretti system in my home, I just can use it in order to have, I know that there are revision heads on, but on the market, and then there are companies selling it, but they're selling it for their own products. And I got no idea what kind of product that was. With the Moretti system, I was able to just put an adapter on, leave the stem in place, even though I didn't lengthen it, I didn't do anything about it, and just put a new head on. And that works well. It's for me, the easiest solution. I can leave the stem in place. I have the reconstruction as I wanted it. I have a stable cup implant, and the patient is walking around drinking alcohol still very happily. Because I couldn't, there's no way of stopping them with those. However, this is a good solution. Is there any question to that? Does that make sense what I'm telling you here? Yes. You have a question? Oh, too bad. Would have been nice though. Good. Then another case. Here the increase of the implant has been a bit higher. It's a 75-year-old male. This is only 3 years after implantation, suddenly becoming pain. Got no idea why. Of course, as I mentioned before, there we do take a probe in order to rule out a possible infection. And we had an aseptic loosening. So what one might suspect is that from the very beginning on, the implant wasn't really stable that much. The primary stability, as I was talking about, was lasting for a few years, and then at some point it wasn't enough anymore, this primary stability, and since the osseointegration didn't really come into place, the implant got loose. Just happened. But the stem looks stable. So there's actually, since I ruled out the septic loosening, there's no reason for me to replace the stem in any case. That one actually, I think, or I feel looks quite good. You here have the anchorage like you want in this coil design stems. So the only problem is the cup. And there again, that was the solution in this case again, left the stem in place. We even had a very good bone stock that we could just have this revision cup with screws, 2 screws. This is not really to keep the implant stable. It just is to prevent it from rotating in the very first place. So what keeps the implant stable is the press fit system. And then you add 2 screws at least. 1 screw doesn't help you, but 2 screws to prevent some rotation of the cup within this press fit system. That's why we're using them. And then, in order to reconstruct the leg length and the biomechanical functions, you do, because it is a bit going up, it's not like it was before, you have to use this adapter system. And there you have just the 7mm length. Of course I have an XL head, but I can't use it because I wanted to have the stem in place. You all know about the probe adapters. Of course, you have been told yesterday. The probe adapters in Germany are actually quite important. She's gone, so I can tell you. The thing is that you have to at least write it in your operation report. Whether you really use it or not, that's up to you. No one can prove that. If you know what kind of implant it is, it doesn't make really sense to use them. However, the company, as far as I understand, you might correct me, says if you don't use it, we won't take any liability on the product. So keep in mind using them, and if you know, because this is my implant, like this has been operated before at my hospital, I know that's a 12-14. Still, I do put it in my OR report that I used it in order to be nice to the company and have still the liability on the product. And then you can have the length reconstruction, and everything is doing fine. Question to that case? Yes, thank you. Oh, this is great.
We don't have the system, so I can ask stupid questions.
Yes.
The only way to do the 7 millimeters would be to replace the stem. If you didn't.
No, there are revision heads on the market, and you could. By that time, when I did that revision, the company which I bought the stem from didn't have revision heads yet. They now do. So now I can use I could use their cheaper revision head. But there are a lot of companies, especially the small ones, where you don't have them on. And if you want to reconstruct those 7 millimeters, you have to use an adapter system. There's no other way. Because there is no chance for me, as I was showing before, there's a big defect. So there's an increase of the cup, and I have to put it here somewhere in order to have enough bone stock, and then the rotation center might increase a bit, but I want at least keep, you can see that here, the leg is shortened. I want at least to have the same leg length to have that reconstructed. Okay? But that wasn't a stupid question though. Good. Solution there. There we got the next one. We have a 8-year-old female. It's like it's always in the report, clinical and radiological signs of cup loosening. Yeah, of course. I mean, who doesn't see that might have a problem. However, it's been 15 years after operation, and according to what I told you before, no biopsy, because it's been so long in place, and I would expect that not to be a septic loosening. However, even though it's been done 15 years ago, this has been an XXL head already. So therefore, I do need some kind of solution in order to reconstruct the leg length and the offset here. You can see offset here, this is the normal offset. Well, not quite normal because there's a coxarthrosis as well, but the offset, the leg length has decreased and the offset is diminished. So I have to reconstruct that in some way. Let's see how I did this time. I used again this jumbo cup. I used the impacting grafting. They look a bit straight down. This is x-rayed a bit too, but actually the cup is constructed the way that this is the angle of the cup where the insert is in. This is just metal part up here. However, I could increase the size of the head compared to what we did before because my implant allowed that, and I had to use this XXL system at least, because we had that before as well. This already was an XXL head, and now I have to use the 3XL system in order to have the offset more or less reconstructed and the leg length as well. So that's the solution for this. Keep in mind, if you do that, that at some point, if you go with this side, if we just go back here, this is XL, you don't even see it. This is before that. Here as well, wait, they don't see the adapter as well. But with the 3XL, you do see it here. And this might give you an impingement. Check that. It has to be a certain thickness in order to be stable with a certain length. Yeah? Otherwise, it won't be stable. It has to have, for the material properties, the thickness has to be there. But this might give you, due to the site, might give you some impingement in abduction and might lead to luxation. And the surgeon has to be aware of that. If it's checked and it's working during the operation, it will work afterwards just as well. But it is something you should keep in mind. Yeah, that was more or less the part of the cup. And now I'm pretty good with the time. I got to hurry up. I'm switching to the stem, because not only the cup reconstruction might give you some problem, but stem revisions might give you problems too. There are the regular problems like fat embolism, mechanical failure, of course wear, osteolytis, and with the cemented stem there might be some cement allergies. So this is like been stated before, and it's the same as we were talking about the acetabulum reconstruction before. You have to plan, you have to think, you have to know what you want, you have to know your implants, and you have to have a solution if something goes wrong. So that's the regular stem we are using. It's a revision stem, certain angles there, certain lengths of those, just you can have a length difference in the stem as well. This is just a sample without a Merete system being used. There was a fractured hip. I had to do a window in the bone in order to get this part out of the bone, and therefore I need to have a long stem. But this is just to show you that the kind of cement-free anchorage for secondary integration, which we regularly use with the goal of minimal migration. That's the standard implant you'll see, just like the jumbo cups I showed you before. When is the good solution for it? For Vancouver B2 and B3 fractures, it's a good solution there in order to reconstruct. There's a Merete system in there again in order to get the length back in the bone, even though you have a chance to do something about the length here at some point. This might not be enough, and then the addition with the Merete system is a good solution. It doesn't work in all cases. Yes, we do know that. If the bone quality is so bad or there's an infect in the bone, there's no way you can do a cement-less revision system in there. So have to be aware of that. Again, it's preoperatively planning, which you have to do. The solution is actually quite easy. We don't have to talk about the trauma surgeon cases where you just use a plate if the implant still is in place. If the implant is loose, we do look at the bone quality intraoperatively. We decide whether we have an old or young patient, and then we do this proximal femur replacement, and there we come to the, if we do acetabulum replacement there as well, then we do use the biomobility cups in order to have some good stability and prevention of luxation. Otherwise, with young patients, we don't always have to use that. This is just a few more cases. There was a 73-year-old male with a dislocated hip where we did he came from another hospital with this replacement so far after fracture with dislocation. And actually that was happening, I think, 11 times. So the first operation which we did was we lengthened the head and we put some adapter on it, but he is still luxating, so that's what we came up with. We wanted to have this in place because it actually was working quite well. So yes, we used an adapter, but we added the MaxiMotion cup to it which we use cemented. I think that mostly it's older people and the cemented system is working quite well. We added to it and we didn't have any luxation so far anymore. So that was a good solution for us. Here another cup, another stem problem, not self-produced. It's a different stem design as we regularly use, even though it's a bit to the corral design. It was a 69-year-old female with sintering of the externally implanted stem. She complained about having the leg suddenly 2 centimeters shortened. So what do you do? Since it was just, I think, 1 year, less than 1 year after the operation, of course we did do a biopsy in order to exclude some septic reason for the stem to sinter. And then, even though I didn't like the cup very much, because the cup belongs there, yeah, it's way too far out. However, the cup was stable, so I did leave it in place, and I did put a cemented stem in. This is just like personal. I tend to switch. If the cemented solution didn't work, I try an uncemented solution. If the uncemented solution is not working well, I'll try to go for the cemented solution. So it's a regular cemented stem, which just fit in there quite well. But in order to reconstruct leg length and offset again, we have to use the adapter in this case, since we had to leave the cup in place with just a 32 size head. However, I think if you look at the result and no luxation and a good function as a result for the patient, I think that is something which you have to try to achieve. Last case. Yeah, then I just am pretty much in my time as well. We can use them for trauma cases as well. This is a lady coming to a hospital, big pain, no chance of really walking on that leg. This is a non-union after this osteosynthetic treatment. It was 1.5 years old. They always told her just be patient, be patient, be patient, and now she's walking 1.5 years old. And that we did do a CT scan. There's no sign of healing at all. Of course, she does have an osteoporosis. You might even recognize that in the x-rays that it is not too much bone stock there anymore, so it must be below 40%. And dementia was starting there as well. So what's the solution for it? Well, solution, again, this is cement-free implant, taking out most of the bone up there. And in order to keep it stable and prevent her from luxating using maxi-motion implant there again, cemented with a 2XL lengthening, having a stable situation, having a happy patient, not understanding why not capable of walking on that for 6 weeks since it's a cement-free stem, but even though she walked on it, it worked well, and no lengthening, no shortening of the leg length or anything. So the implant obviously kept in place and was stable. Yeah, you had to listen to me for about 1.5 hours almost. I hope it didn't tire you too much. For those of you who are still awake, thank you very much.